Hello, everyone. I'm Marcia Mott, and welcome to the UF Health Wellness University webinar. Thank you so much for joining us today as we discuss kidney cancer. I'd like to introduce you to our speaker, Dr. Padraic O'Malley. Dr. O'Malley obtained his medical degree at Saba University School of Medicine in the Caribbean Netherlands. He completed a urological residency at the University of Toronto and his urologic oncology fellowship at Weill Cornell Medical College. Prior to joining UF Health, Dr. O'Malley was an assistant professor at Dalhousie University in Nova Scotia, Canada. He's a member of the Florida Urological Association, American Urological Association, Canadian Urological Association, Endourological Society, and Society of Urological Oncology. His interests include urological oncology, robotic and surgical techniques. He also currently serves as a sub-investigator on a number of clinical trials for bladder, kidney, and prostate cancer. Recently, UF Health Urology was ranked number 32 in the nation by US News and World Report. We're pretty proud of this accomplishment. If you have any questions for our speaker today, you can submit your questions at any time using the Q&A button at the bottom of your screen. If you wish to turn on the closed captions, there's a button at the bottom of the screen as well. Or if they're bothersome to you, you can also turn them off by clicking on that as well. At the end of the presentation, I'm going to go ahead and read any questions that we have, but I'll read your question anonymously. We're going to try to get to as many questions as we can. Dr. O'Malley, I'm going to go ahead and turn it over to you now. Thank you so much.
All right, thanks very much, Marcia, for that introduction. Hi, everyone. Nice to meet you. Thank you for having me to give you this talk. Just get my slides up here. All right, and if you have any issues at any point, viewing these or whatnot, let us know. We'll see if we can do something to sort of try and correct that for you. So we're going to talk a little bit about kidney cancer and sort of from the more sort of localized or very early stages to the more advanced settings and sort of some of the newer accomplishments, I would say, of our research as a field and how we're improving patient care on a sort of daily and yearly basis. Couple disclosures here. These are two companies I do some consulting for, none of which has any impact actually or any bearing on kidney cancer. So shouldn't really have any issue with today's talks. So three main objectives. We're sort of going through the disease spectrum. We're going to talk a little bit about what are small renal masses. We're then going to talk about patients who have more aggressive or larger burden disease, but still confined to the kidney. And then finally about patients who unfortunately have kidney cancer that has started off in the kidney, but has also now spread elsewhere in the body and is obviously a more serious situation. So we'll go through those three, and that sort of helps address most of the clinical scenarios most patients with kidney cancer or kidney masses find themselves in. Kidney cancer, some of you may be very well aware of it, some of you may not. We saw about 76,000 new cases in the US in 2020. That number increases every year, pretty stepwise, about 2% every year. So it is a cancer that continues to be on the rise. Amongst the top 10 cancers in men and women, it's the sixth most common in men. It is more common in men and women, but still certainly a significant number of women suffer from kidney cancer as well. And we see it's the eighth most common cancer amongst women. Most patients are in around their 60s, but I have operated on people anywhere from the age of 19 to 96. So there is a wide spectrum, but most patients fall in those sort of middle years. The survivability for these cancers range to, excellent for patients with localized disease. So, tumors that are on the smaller side confined to the kidney around, on average 93%, to, a much bleaker outlook for those with metastatic disease. Traditionally, what we'd say about 12% are alive at 5 years. Fortunately, that's improved significantly with some of the newer advances, and we'll talk a little bit about that today. So, this rise in kidney masses, this is actually data from the United Kingdom. So this is not just sort of a US only phenomenon. We see it in other industrialized countries. So we see it in Canada, Australia, New Zealand, the UK, France, Germany. And you can see here in the UK data, there's been a gradual rise over time from the mid-90s to now. And it's expected that it will continue to rise. And one of the things to notice that, it's expected to actually be one of the fastest increase in cancers over the next 20 years. So this is likely going to become a bigger problem in the future and not become less of an issue. So we certainly have a lot of work to do in this area. So most patients with kidney tumors, the vast majority, fortunately, are diagnosed with what are smaller renal masses. And so, a lot of patients we see will come in, they'll have a CAT scan done. And oftentimes that CAT scan is not done for a kidney cancer, but done for some other completely unrelated reason. And incidentally, they see there's a spot in the kidney. And, most patients, of course, the thing they're worried about is, hey, do I have kidney cancer? And if so, what do I do? This is a long list of conditions of masses you can have in your kidneys. And some of these sound kind of scary, like rhabdomyoma or oncocytoma or angiomyolipoma. But actual fact, these are all benign lesions, all these that are listed here. And it's important to keep that in mind because, a lot of these lesions, particularly when they're small lesions in the kidney, can actually be benign. They're not necessarily cancer. And so that's important to keep in mind. And so when we talk about these small renal masses, we're talking about lesions that are less than 4 centimeters. That is not the same as kidney cancer. It does not automatically mean that, okay? So about a quarter of these lesions are actually benign. And whether they are benign or cancerous, generally speaking, these all grow very slowly. They tend to be what we call indolent, or in other words, lazy. They don't grow very rapidly. They're very slow growing. They grow about, 1 to 2 millimeters a year. The risk of these spreading, generally speaking, is very low. They're usually about less than 2% chance of actually going somewhere else or escaping the kidney. And, in actual fact, a large number of these probably do not require any treatment. Some do, but a good number of them do not. And a lot of the treatment that we do for these is actually really driven by patient preference rather than, hey, we need to take this out. So it's important to keep in mind that when you have these smaller masses, a good number of them are benign. The vast majority of them are slow growing. And so you've got time to weigh what your options are and which options are going to be best for you. So there's a couple different options we'll talk about. They range from, surveillance. We can just keep a close eye on this with repeat interval imaging. And that may ensure that, hey, this thing isn't growing rapidly. It is that slow growing process, or, some of these patients, they don't grow at all. And we just keep an eye on it. If it never becomes a bigger problem, we just leave it alone. Some patients, we say, hey, I want it out, or, we say you would probably benefit from having surgery on it to remove it. And a lot of times these nowadays are done robotically. And you can see here on the lower left, this is sort of what the current robot that we use oftentimes looks like. So this, is a sort of less invasive procedure than traditional open surgery, and allows a quick recovery. And then somewhere in the middle, we have what are sort of called ablative techniques. So rather than going in and cutting this out, we basically stick a needle into these tumors and kill them either with heat or the opposite, we freeze them. And so, it's kind of like this freezing gun here. We freeze the tumor, and that kills off the tumor without affecting the normal tissue around it. So all of these are really good options for patients with small renal masses. There are some nuances as to why we may choose one option over the other. But even in most case scenarios, all three are reasonable options. And so the first option, as I said, is sort of surveillance. As I mentioned, a quarter of these are benign anyways. The vast majority are very slow growing, and the risk of them sort of spreading elsewhere is very slow. So if you take patients with small renal masses, and if you did nothing, the chance that 5 years later they're alive and not dead from kidney cancer is pretty close, if not equal to 100%. So by and large, most of these, you have plenty of time to decide what to do. And this isn't just data from one study. This has been shown in multiple studies. This result is a very consistent result. So we know from thousands of patients that this is true. That being said, this is generally speaking for tumors less than 4 centimeters. No one has really robustly validated that for larger masses. When they get above 4 centimeters, and certainly when they get above 7 centimeters, we know that they start to grow a little quicker. We know that the risk of them spreading elsewhere starts to go up. But even in certain specific patients, observation or surveillance may still be an option. So I have some patients with larger masses who, are much older, maybe have a lot more medical comorbidities. And for them, watching it is actually a better option for them than trying to do surgery, which, they would not tolerate as well. And there's some nuances to that. And it does take a lot of time to sort of go through why that may be a good option for some patients. But that's what we do. Active surveillance, still not convinced, not sure you want to just watch it. One thing we can add in is what's called a biopsy. As I said, a quarter of these are benign. If you biopsy and it's benign, it's very easy then to sort of say, yeah, let's just keep an eye on it and not do surgery. For some reason, and I'm not sure where it comes from, there is a large sort of misconception out there that, this idea that once the air gets to it, it'll spread. That is factually incorrect when it comes to small renal masses and kidney biopsies. Even doctors used to think that, 40, 50 years ago. You can see all the studies I've listed here at the bottom. It's been shown to be safe and effective over and over and over again. So this idea that, once the air gets to it, it's going to cause your tumor to spread just is not true. And anyone who tells it to you either doesn't know what they're talking about, or shouldn't be telling you that because, they obviously have got the facts wrong. And just to put this in perspective, amongst the top 10 most common cancers in men, 9 of the top 10 are diagnosed by biopsy. So prostate cancer, it's diagnosed by biopsy. Colorectal cancer, diagnosed by biopsy. Kidney tumors are the only ones that are not diagnosed by biopsies in men, in the top 10 most common cancers. And in women, it's one of only 3 of the top 10 most common cancers that's not diagnosed with a biopsy. And unfortunately, the reason we don't biopsy these is that most patients say, just take it out. And a lot of urologists are like, well, it's less work for me if I just book you for surgery, get paid for the surgery and do the surgery, than if I sort of talk you through what's involved with the biopsy and then interpreting the results. And then you may end up going for surgery anyways. That said, we know the biopsies are very accurate. They're about 94% accurate. Different types of kidney cancer can behave very differently. So in knowing that can actually really change what we do. And it's estimated that about 30 to 50% of patients, if they had had a biopsy before surgery or surveillance or before ablations, would actually change what they had done based on the information from the biopsy. So, we think it's a good option for patients. You don't have to have it done, but we think it can be very informative and helpful. The ablation techniques, this is sort of somewhere in the middle. You're not watching it, you are doing something about it, but it tends to be less invasive than surgery. And there's 2 ways you can do this. You can either heat it up, which is called radiofrequency ablation, or RFA, or you can do what's called cryoablation, which is where you freeze it. The data shows that cryo is more effective. That's what we do at University of Florida. This traditionally is done percutaneously. So what that means is that it's actually not done here by the urologist, it's actually done by the radiologist. We set it up for you and they do the procedure, where they basically give you some local anesthetic in the skin, and then they basically place a needle through the skin into that tumor in the kidney, and they freeze it. So this is a good option for these lesions that are about 3.5 centimeters or less. In those, it's like 92 to 96% effective. I would say probably more like 94 to 96. So yes, it's not going to be as good as surgery, but it's still an A+, okay? And there are some limitations, right? If there's a lot of bowel nearby, or if it's a very anterior tumor, or if it's near the heart of the kidney, sometimes they can't do this. But generally speaking, it is a great option. And the nice thing is usually it does not require a hospital stay. And as I tell patients, if you had it done on a Friday, you can go back to doing cartwheels on the Monday. So it's very well tolerated in the vast majority of patients. The sort of gold standard, or the traditional gold standard, has been surgery. It is the most definitive and the most accurate as far as, cancer curability and pathology diagnosis. That said, it's also the most invasive. So it's got the highest risk of complications, whether that be bleeding, needing the entire kidney removed. Thankfully, you know, the way that we do these now robotically, the rates of these, you know, having a significant bleed or having to have your entire kidney removed are generally quite low. It doesn't mean it doesn't happen, but generally speaking, it is not a common thing. But the risk is certainly higher than ablation or surveillance. If a patient has a small renal mass and there's no invasion of blood vessels when you take that out, it's about 98-99% effective at 5 years. So it is a very, very effective treatment for these small renal masses. And 99% of these patients will not need additional therapy, i.e. they'll need no radiation, no chemo, no immunotherapy. The surgery will kind of be one and done. So it is a very good treatment option. It just may be that many patients with these masses may not even need this, okay? And like I said, unlikely to ever need any additional treatment. It is also the most likely, however, to impact your renal function. That said, the vast majority of patients, it's not going to do much to that. We'll talk a little bit more about that later on. So this is what the current sort of robotic instrument and device looks. These are sort of ports in the patient's abdomen. And so these small little incisions are how the surgery is done. And you can see some of the monitors behind the arms there. It takes a couple hours, but again, very minimal blood loss, very minimal sort of recovery. Traditionally, this is kind of what you'd see. This is a kidney, and you can see the tumor on the surface there, and that's been cut out. So that's sort of how open surgery is done. You can imagine for a surgeon to get their hands in on that kidney like that, you need a little bit bigger incision than the small little ports from a robotic procedure. So, you know, some incisions patients will show you. You can see this gentleman here had a very large incision. The day of those, by and large, for partial are gone. You know, you should not expect that type of incision for a partial nephrectomy. This lady here, you can see her incision is much smaller. That is a much more common type of incision. It tends to be more interior now because we tend not to dissect along your ribs, but that's the type of small incision you could get with an open partial. Again, neither of those incisions are as small as robotic, so most patients usually have a robotic procedure these days. So just to review those sort of small renal masses, the vast majority of these patients are going to be, you know, alive and well and not dying from their cancer 10 years on, irregardless of what treatment they choose. Not all of these small renal masses are cancerous. A quarter of them are benign. Biopsy is a safe and accurate means of getting additional information to help guide your management. And in some patients, surveillance may be a better option than intervention, particularly older patients with more health issues. We try not to be ageist. So if you're 90 and extremely healthy and you sort of say, I really want this out, or we think you need it out, you know, like I said, we've operated on people older than that. But by and large, if you're 85 and you've got a lot of medical issues and you've got a 2.5 centimeter mass, that's very unlikely to ever kill you before natural causes will cause you to sort of shuffle off this mortal coil, if you will. So us intervening or doing surgery on you really doesn't make sense for you or your disease. Again, ablation and surgery, if you need some intervention, are both excellent treatment options. Both are very effective. And generally speaking, both have overall very low complication rates. So that's sort of the best case scenario where you have a very smaller lesion really confined to the kidney, and we can treat these very appropriately, either with treatment or without any intervention. The next group is sort of when we talk about lesions that are sort of a bit bigger, they have a greater chance of spreading, but may not have spread already. So there's no spread to, say, the lungs or the bone or things like that. But these are essentially sort of more like a ticking time bomb. It's only a matter of time that if you don't do something about it, they will do that. And you can see that when you look at how many patients are free of cancer 5 years after surgery. It's a broad range, right? So it's 35 to 85%. So 85% cancer-free at 5 years, that sounds pretty good. 35% sounds not great at all. And so, you know, the question is, why is there such a discrepancy, or why is it so wide? In the first setting there, when we talked about those small masses, we said that, you know, surgery was 98, 99% curative. So that's a, you know, 1% margin of difference. Now, all of a sudden, we're talking about a 50% margin of difference. And that's because these tumors can be very different. You can have a tumor like this, which is 7 centimeters, and you can have a tumor like this, which is 7 centimeters, but it started to spread along the veins and started to want to go places, but hasn't gone elsewhere. So it's a very heterogeneous group of lesions and of biologies. And so that's why you have this difference in how these patients do. And, an example of this is these two scans. These are not patients of mine, these two actually, these are from the internet. This is a mass that is 7 centimeters, but it is well localized. This is the type of thing where you remove this kidney or part of this kidney, this patient is probably more likely in that 85% chance of being disease-free 5 years later. Conversely, this patient down here fits kind of into the same category. It's greater than 7 centimeters, but it hasn't gone anywhere. But you can see clearly here, this tumor has completely replaced the kidney. It started to grow into the veins here, and it started to come very close to the bowel and other organs and the muscle behind the kidney. And so, this patient is much more likely in that 35% group. So that's why there's such a discrepancy in these patients, is that they really are a very mixed group of tumors. Surgery is the treatment of choice for these. Generally speaking, you can see that large mass there. You're not going to be able to sort of take out the tumor and leave normal kidney behind. So that usually means removal of the whole kidney. Patients, one of their biggest concerns is, okay, I have one kidney removed, I have one left. Am I going to need dialysis? And, the short answer is no, but it depends. So, this is an example of a study was done. It's done with almost 3,000 patients in Australia who underwent surgery involving the removal of either the total kidney or part of the kidney. And you can see that in those who had the total removal of kidney versus the partial, there was a slight difference in the number of patients that needed dialysis. But it was still 5 cases in 1,000 person years. Basically means, a handful of people or less in both groups. And statistically, it wasn't significant. It was 5 versus 4, amongst 3,000 patients. And so really the risk of needing dialysis after having either your entire kidney out or part of your kidney out is very, very, very low. So even if you have your whole kidney out, the chances of you need dialysis really is not much different than if you never had surgery at all. The one caveat to that is that you can see here is that if you had kidney disease before surgery, i.e. if you have poorly controlled diabetes and your kidney function is already affected, so this is what they call preoperative kidney disease, you have a 15-fold higher risk then of needing dialysis in the long term. So, we talk about health maintenance and things like diabetes and making sure you sort of do the right things for your health. These are the reasons why it becomes very important. If you have normal kidney function going into any of these surgeries, you're probably going to have fairly normal kidney function afterwards, and you're not going to need, dialysis. If you've got bad kidney function going in, your risk go up significantly. But that does mean that most patients are not going to need additional therapy like dialysis after a surgery to remove a kidney. So, again, we said there's a large portion of these patients are likely to recur. So anywhere from 15 to 65% are going to have a recurrence of the disease. There are a couple of things we do to sort of try and tease out who those people are. Most of these patients, just doing a chest x-ray before surgery is not really sufficient staging. Most of these patients really need a CT of their chest to really look closely at their lungs, because that's usually the place these like to spread to. And getting a good baseline before surgery is important so that afterwards, if anything changes, you know exactly where you were before and where you are now. Some people ask about PET scans. Generally speaking, PET scans for kidney cancer are not very helpful. Many kidney cancers are not what we call PET avid, i.e. a PET scan won't light them up, whether it's in the kidney itself or the kidney is spread somewhere else. The PET scan may not work for them. So PET scans are not very useful. Generally speaking, a CT is better than an MRI. There are some exceptions to that. Some cystic lesions or cases where there's a thrombus, i.e. some tumor along the vein, sometimes the MRI can be beneficial as well. But one thing that a lot of patients ask is, what can I do to sort of stack the odds in my favor, given that there is this, real possibility of having a recurrence? What can I do to try and increase my chance of it not coming back? And one thing we've tried is, using systemic therapy. And so, what is systemic therapy? In most cancers, systemic therapy refers to chemo. And chemotherapy is kind of like a nuke. It kills everything. It kills the cancer, but it also kills a lot of healthy tissue as well. And so that's not ideal because obviously that can have significant side effects. And in kidney cancer, we actually don't use chemo. We use what's called targeted therapy. So many of these actually tend to be antibodies directed at certain signals that the tumor cells use to help them spread. And so targeted therapy is much more like a smart bomb. So it's much more targeted. And because of that, it tends to be better tolerated and have a lower risk of having side effects. Some of these drugs, for instance, this sunitinib that we use in some cases now in kidney cancer, are actually oral medications. So it's not like having to come in and have an infusion. Some of these drugs work on multiple steps in the pathway of these kidney cells. And so systemic therapy in kidney cancer does not involve chemo. It involves more targeted specific therapy, smarter therapy, if you will. So, we sort of said, well, can we use these drugs, which we know in patients who have had spread elsewhere, can we use them in this cases where patients haven't had spread to sort of decrease the chance of it coming back? And we've looked at it before surgery, and we've looked at using it after surgery. And unfortunately, it's not really been a success story. There's not been a survival benefit with these. And it's not like we tried once. This here is a list of a number of studies that were done trying to use these drugs before surgery for patients with advanced kidney cancer. And unfortunately, none of these studies showed a benefit. This here is a list of the studies that were done after surgery. And only one of these really showed a benefit. And the benefit it showed was that it took longer for your kidney cancer to come back, but it did not change how long you lived overall. And so, where these drugs can have some side effects, they're better than chemo, but they still have some side effects. And these patients take these continuously. If it's not going to make you live any longer, what's the benefit of really taking it? So unfortunately, we've not been very successful there. The ramifications of that, obviously, not only are there the cancer ramifications, but also for many of our patients, that leaves them sort of, very anxious because, they come back for their scans. I think a lot of patients feel a loss of empowerment because, they are more than willing to do what they could do to try and optimize their chances of doing better. And there isn't really anything they can do. And so it kind of leaves them sometimes feeling a little bit helpless. And, that has a lot of psychological and quality of life effects on patients' well-being. So it can be tough for patients, they're just sort of sitting there each time coming back for a visit with their fingers crossed. And it's like, can I keep living my normal life? Or are things going to change? Is, someone going to drop a hammer on me? And so, we don't like to see patients in that sort of setting. And we're always trying to sort of figure out ways to not do that, to help empower them, to give them options that may help them benefit down the road. So, one way we do that at University of Florida is we do a lot of clinical trials. It's basically, the next sort of thing down the line, and sort of, as I say here, it's new ways to do things better. We see it as an opportunity for patients to be empowered to sort of help research disease, but it also gives them access to, tomorrow's treatment today. And we do this sort of in a very team-based approach. So, this involves our medical oncologists. This is Dr. Chaskell and Dr. Ramrine, two of our medical oncologists who do a lot of the clinical trials with us. Ms. Shelley is our nurse navigator. She helps a lot of the patients navigate through the trial setting. Here's myself, Dr. Crispin, who's one of my colleagues, another surgeon who does a lot of these trials. And so, we've tried to use trials to give patients options to sort of help empower them, but also give them access to care that's not available today, but will be tomorrow. And, what this meant in the last 8 months, we've had this trial, the PROSPER trial. This was an international trial. And basically the idea behind this trial was that patients either went ahead and had surgery like they would for these locally advanced disease, or they got randomized to get a dose of immunotherapy, which is a new type of therapy that you probably see a lot of commercials for. They got a single dose before surgery, and then they got several doses after surgery. And so they plan to enroll about 800 patients in this. We were one of the higher enrolling centers in this internationally. Within 8 months, this study filled up completely because patients really wanted this opportunity. And we've seen, patients have done very well. The results for this should be within the next 1 to 2 years. This was one of 3 trials being done with these newer immunotherapy drugs. So, in a year's time or less, we may see a complete change in how we're treating these patients, and hopefully moving everyone from that 35% cancer-free at 5 years up to that 85% or higher, where we really want to see people succeed. But again, the only way we can sort of improve is by testing and doing these trials. Most of these trials, are not just sort of randomly drugs picked out of a hat kind of, or ideas picked out of a hat. Most of these have some previous data to support their use. And we'll talk a little bit about the immunotherapy and why that was chosen as a good drug to use in this setting. So, in this setting, we're looking for a real game-changing study. We're hoping these latest studies that have just finished are going to be that. The idea is that, by unleashing our body's immune system using immunotherapy, not only can we get better responses and decrease the chance of this coming back, but we can also make that a long-term cure for these patients so they can go on and live happy lives doing things they like doing rather than seeing folks like me. Again, all of this is possible because of this team-based approach. It's really multidisciplinary and multimodal of care. So it's different types of physicians using different types of therapies that treat the same patient in different times to sort of optimize their outcomes. And that's sort of the new wave across specialties in cancer care. And if you're not getting multimodal or multidisciplinary care for advanced cancers of any sort, you're probably not being treated the best way possible. So that moves us into sort of the, for lack of a better word, the end of the road, metastatic kidney cancer. So this is sort of where your kidney cancer is no longer confined to the kidney. And so basically the horse is out of the barn. Traditionally, we would have said the 5-year survival rates are about 12%. That's pretty crummy. I will say that was based on older drugs and prior therapies. And fortunately, this gets better every day. And those numbers are significantly higher now and better. And that's because of newer drugs and trials that we're doing to continue to improve that. So historically, when people had kidney cancer that had spread elsewhere, basically what we gave you was surgery. We were still remove the kidney. And then we gave you this awful sort of what was called immunotherapy and chemo, this combination. And this stuff was really toxic. And basically, if it didn't kill you, what doesn't kill you makes you stronger, I guess. But this ended up in, killing about 5% of patients and curing about 5%. So, 90% of patients just had horrible side effects and didn't cure them. 5% it cured, those were the lucky 5, but 5%, it killed. So, this was really, I wouldn't say ideal. It was just bad medicine. Fortunately, things have gotten better. And so many years in the early 2000s and even up to 2018-ish, the de rigueur was really surgery and then the targeted therapy. And so that was using these drugs I talked about, the TKIs or VEGF inhibitors, like sunitinib, that sort of target these receptors in the cancer cells. But this was not curable, right? This is just controlling your disease, buying more time, but ultimately is not going to cure patients. Currently, what we use now is we use a combination of immunotherapy, the newer type of immunotherapy, targeted therapy, as well as surgery. And this has kind of been an evolution that's happened over the last sort of 5 years. So surgery in this setting is what's called a cytoreductive nephrectomy. And so that's basically removing the kidney where your disease started, even though you have spread elsewhere. And we know that in the patients who had metastatic disease, that on average, it got you at least an additional year of life. And this was in the setting of older systemic treatments. When the newer drugs called sunitinib and these TKIs and VEGFs came out, we assumed the same. And so we continue to practice surgery and then these treatments, but we didn't actually study it. And there's multiple reasons for why that is. Mainly it's because surgeons and medical oncologists weren't working together as closely as they do now. There was a trial done in sort of 2015 to 16, and basically in those patients, they got the drug, and half the patients got surgery and the other half didn't. And what they found was that there was no difference in survival between groups. It didn't matter if you had surgery or not, you end up doing about the same. Now, that is an oversimplification of it. There was still, in select patients, we'd still stay a role for surgery, but by and large, it meant that, you know, we were probably operating on too many people. And this is sort of, you can see here, this is the survival curves over time. So this is the number of people alive, and over time of these patients with metastatic kidney cancer, whether they had the drug alone, which is the red line, or they had the drug and surgery, which was the blue line. So really, statistically, there was no difference in these patients. So, you know, for most surgeons, this was kind of our reaction. You know, here we were, we thought we were really helping people, and in actual fact, we really may not have been doing much for them. There are some limitations to any studies that are done, and, you know, there were certainly limitations to this study. So, you know, this did not mean that patients did not benefit from surgery. It just meant that they had to be more carefully selected. So this was a big study and really changed things, and that was 2018. What happened, though, was that in 2019, you know, it was like, what's the next thing that comes along? And that's these two big studies. And these were the first studies of immunotherapy. So you see these commercials on TV now for melanoma and lung cancer. And usually it's the guy running around playing with his grandkids saying, now I have more time with my grandkids. And, you know, it looks pretty happy and looks like he's doing, like he's not sick at all. A large number of patients on these drugs actually do look like that. They look very well, and you wouldn't be able to pick them out on the street. They really do tolerate these very well. So these two studies compared the standard, which was the sunitinib drug, and they looked at using these either combination of two immunotherapy drugs or an immunotherapy drug and one of these older type style of drugs. And in both cases, both of these combinations were better than the standard, which was this old drug called Sutent. And you can see that the median survival in patients on Sutent with metastatic kidney cancer was about 2 years. In the patients who got immunotherapy, they did so well that they didn't really have, by the time they sort of published the results, they hadn't reached the sort of median survival yet. So basically, patients were doing really well. And that's the same with the pembro and axitinib combination. These patients did very well for a very long time. And so these really changed a lot in kidney cancer. And they work based on immunotherapy. So they basically allow your body's defense mechanisms to go after these kidney cancers themselves. And that's why we think they end up in the long term. Patients treated with these can have very durable responses where they can go many, many, many years, if not forever, without having their kidney cancer come back. So, you know, this is sort of the timeline of the sort of treatment of metastatic kidney cancer and what the sort of standards are. Currently, we're looking at how do we mix and match these different immunotherapy and other drugs together to maximize therapy for patients. And we have a study currently that looks at that. But it's really been every year, the last 5 years, there's been a sort of a game changer. And it will continue to be that way. So it's an exciting time for us as surgeons and as urological oncologists and medical oncologists, because every year there's something better we can offer patients. And, you know, at the end of the day, we all got into this sort of field because we wanted to help people. So it's very exciting and rewarding to see patients continue to benefit from these. You know, if we had a wish list of, you know, what can we do to sort of optimize care is, you know, when do we fit in surgery? There are some clear examples in some patients. You know, some patients will come in, they'll have metastatic disease, but they'll have a large tumor in their kidney, and then they'll have 1 or 2 small spots in their lungs. Clearly, most of their cancer is in the kidney. So in those patients, oftentimes what we'll do is we'll do surgery up front, and then we'll do the immunotherapy afterwards. Some patients come in and they've got a not so big mass in their kidney, but they've got a lesion in their bone or two, some in their lungs, some in their liver, maybe even the brain met. And those patients obviously should get immunotherapy first, because that will attack the cancer wherever it is. And at a later date, we may then go in and take care and remove the kidney, because there is a benefit to that. But there are a large number of patients who fit in the middle there. And those are very tricky to figure out, what the best timing or sequence of therapies is. And we're still trying to sort of really tease out the fine details in that area. And the other thing is, radiation is not something we've typically used in kidney cancer. There are select cases, though, where it can be very helpful. And we're finding out more and more about that. And it may be that using either radiation or surgery or a combination, that we can almost prime the immune system so that when patients receive immunotherapy, it may work even better, because their immune system will be charged up, that when you give the immunotherapy, it will be more effective at killing these cancers. Currently, we have this trial, the Pedigree trial for metastatic kidney cancer patients. Basically, this looks at using a combination of therapies, starting with standard immunotherapy, based on one of those studies that was reported in 2019. It used the combination of these two drugs called ipilimumab and nivolumab. Don't blame me, I didn't make up these names. The other names for those drugs are Opdivo and Yervoy. I didn't make up those names either. And of course, all these drugs have two names and neither one's easy. So these patients basically all start off on these drugs as they would normally. About 5 to 10% of patients, once they have these drugs, all their cancer will disappear. And so those patients continue on single drug with the nivolumab for another year. Those patients who, it's a small number, it's less than 5%, who have progression, are switched over to a different type of drug called cabozantinib. It works a different way, a different mechanism. And clearly the immunotherapy combination is not working the way we want it to. So we switch them over to that other way. And then the vast majority of patients sort of fit in the middle there, sort of about 80–85% of patients, where they have a good response. So a lot of their tumor shrinks down, but it doesn't completely disappear. And we don't know, are they better off maintaining on that one drug continuously, or do we add in a different type of drug, this cabozantinib, that works a different mechanism? Do those patients do better? And the idea is that, you've hit it once from this angle, you've hit it from another pathway, you may get an even better response down the road. So that's what the Pedigree trial is. It kind of offers the treatment of tomorrow, today. But this, again, is one of these large trials being done across the country. We have a good number of patients recruited to this already, and patients tolerate all the therapies quite well. And again, I think it's a good way for patients to be involved in their care. Traditionally, we've always said, stage 4 kidney cancer is essentially not curable because the disease is spread somewhere else. And, that would have been a fact. Fortunately, that is a fact that is changing more and more every day. We still tell people this is a terminal diagnosis, but we are starting to see more and more patients with the combination of surgery, immunotherapy, maybe radiation, some other therapies, who have non-curable disease live many, many years. And essentially, that really is a definition of cure then. So, we are in an era where we are transitioning from where we once used to say this is incurable to, hey, we may actually be able to cure patients. And that is a really exciting thing. And obviously big news for many patients who have this diagnosis. We're not there yet, but we are getting closer and closer every day. The newer treatments are more effective, they're better tolerated, so patients can get their treatment, it works better, and their quality of life is maintained at a higher level throughout the treatment. So, it really is a new wave for patients. As I mentioned before, multimodal therapy, we certainly use it in metastatic kidney cancer. We also use it in the locally advanced disease. As I said, in any cancer, I think it's important for advanced disease because there are different tools we can use in combination or sequence to really get the best options, the best treatment for patients. And hopefully one day that leads to an increase in cure and an increase in the quality and quantity of patients' lives. And I think, That really takes a big team effort from your surgeons, your radiation oncologists, your medical oncologists, even the pathologists, radiologists. And I think that's one thing we do exceptionally well at the University of Florida, because we do work as a team. Myself and Dr. Crispin, we're two surgical surgeons here. We meet every week with our medical oncologists and radiation oncologists at least once a week and talk about patients on clinical trials and who we can enroll in clinical trials to really try and optimize patient care. And we also have meetings every 2 weeks where we discuss more complex advanced cases as a group with the addition of radiology and pathology, really to try and figure out as a group what the best treatment options for patients are. And that's really, in this day and age, that is what patients need and what they should be getting. It's just a little thank you. Dr. Sue is the head of our department, who's also a urological oncologist who does a lot of prostate and localized kidney disease as well. Dr. Paul Crispin, who does a lot of more advanced kidney cancer, as well as myself. Our other colleagues in the other departments, again, it's a big team effort, and our clinical research team. These people are the sort of unsung heroes who help make sure all the check boxes are ticked, that all these patients can get through this trial process and really take advantage of these treatments. These here at the bottom are some helpful societies that have web pages and have information on kidney cancer that is usually, most of these societies are actually patient run with input from medical professionals. So the information overall tends to be quite robust and, very rigorous as far as, evidence-based. And so they are helpful sources for patients for identifying and seeing more material on kidney cancer. So with that, the last thing I'll do before I say thank you there and take questions is, this is a trial we are trying to open up here at the University of Florida. We're hoping to open it this fall. It's called a renal mass biopsy trial. And the idea is that for patients with these masses that are less than 4 centimeters, we are trying to basically see how often it really does change patients' decision of what they decide to do. We are also looking at, is there RNA and protein in your urine that can help us detect if it's a cancer or not? Because then, if we could just do a urine test to tell you if you've got a kidney cancer or not, that'd be less invasive than a biopsy would be. It's also the first genomic study of small renal masses. We know there are some genomic changes in kidney cancers and advanced kidney cancers that make them more likely to spread elsewhere. No one's really looked at that in small masses. And so we're hoping to do that. And this study, involves a large number of people, anywhere from the School of Journalism all the way to, the pathology and genomics. So it's a really multidisciplinary approach to these small renal mass patients. And so we're hoping to open that in the fall. It's a renal mass biopsy trial, and the shorthand term for it is the Rambo trial, which I kind of thought was quite nice. All right, with that, we'll end there, and I'll take any questions that anyone may have, I guess.
I like the Rambo name too. That's kind of fun. For some of those trials are like the drug names. So
yeah, I thought it was a little more catchy.
Yeah. So we have some great questions that have been submitted. And how does someone tell the difference between a cyst and a tumor? A urologist mentioned I have a cyst, but the nephrologist has never mentioned it.
Yeah, so that's an excellent question. Cysts tend to be sort of fluid-filled lesions. And so some cysts are concerning, some are not. There is a classification scheme that we use to sort of grade how complex your cyst is. It's called what's called a Bosniak Classification. And that really determines whether you need anything done about it or not. A simple cyst is basically what's called a 1 or a 2. And the risk for malignancy of those is so low that most times if you walk into our office with one of those, we say, hi, bye, and have a good life. Because they are not concerning, 56% of people over the age of 50 will have a cyst in their kidney. That's how common it can be. And so those really do not need any further follow-up and are not of any concern. On the flip side of that, you can have cysts that have a solid component within them, or when you're given the contrast dye for a CAT scan, you see that there is some what we call enhancement. And so if they have a large amount of enhancement or a solid component, those are more in what we call the class 4. And those are about 85% of the time are actually malignant or cancerous. So those obviously need to be treated differently. There is a sort of group called 2Fs that the F stands for follow. The risk for those being cancerous is less than 5. And if it's a 3, it's about a 50-50, although I would say it's less likely to be cancerous for finding over time. So it depends on the classification of that cyst. The way to tell that is usually a scan, either a CT or an MRI, but it has to be done with contrast. So if you have poor kidney function, then you should get an MRI with contrast, because the contrast for an MRI will not affect your kidneys. The CT scan, the contrast may if you have poor kidney function. If you have normal kidney function, it will not do that. So you need a CAT scan to really determine that. And a urologist will know much more accurately than a nephrologist will. The nephrologist is like a medical kidney doctor, but they don't cut things out of kidneys. They don't look at cysts or masses in your kidneys. The urologists do every day. So your urologist has the more accurate information there.
Okay, good answer. Thank you. Are there any modifiable risk factors for kidney cancer?
Yeah, so, it's interesting with the increased rates of kidney cancer, obviously people have always looked at what causes kidney cancer. There are some genomic conditions or genetic conditions that people have that can lead to kidney cancer. Most of those, usually people are fairly well aware of nowadays, but not always. And there tends to be a family pattern of things, and it's not always of kidney masses. There are some other people who, there is one condition called Hlrcc, where these patients basically, a lot of women in the family get a hysterectomy, have their uterus removed at a very young age, like early 20s, for fibroids. And then, 10 years, 20 years later, you see one of these ladies and they've got a kidney mass. And it's like, well, do you have any sisters? Yes. Have any of them had hysterectomy? Yes, 3 of them. And you're like, well, let's get a little more interesting. So there are genetics. Those are non-modifiable. The modifiable risk factors, the only real 2 that have been very well identified, and those are not slam dunks, are obesity and smoking. And obesity is very interesting in kidney cancer. It's been shown to increase your risk for kidney cancer. But what's interesting about it is that in patients who are more obese, although they're more likely to get kidney cancer, it tends to be less aggressive. So this is called the obesity paradox in kidney cancer. It's still something that's under investigation because there's a lot of other things that go into that, right? So, there's things like diabetes and stuff and, cholesterol issues that sort of run along with obesity. So it's not clear, is that what drives this, the biology behind it or not? But that's one aspect. So I don't know if that means you should gain weight or lose weight. Depends how you look at it. The other one is smoking. That does increase your risk for kidney cancer. It doesn't do so to the extent it does for lung cancer, right? Or the other urological one that people are less aware of is bladder cancer. So smoking tremendously increases your risk for bladder cancer. For kidney, it increases it, but how much? I don't know, but quitting smoking is always a good idea for multiple reasons. Cardiovascular, pulmonary. I think those are bigger reasons to quit smoking rather than worrying about having a kidney cancer. But those are really the only real modifiable ones that we sort of really have a good handle on.
Okay. And are any of those risks that you described, are any of those the reason that women have a rise in getting kidney cancer, the increased rates for women?
No, I think it's just, some of this is access to care and things like that. We don't know overall as a whole while they're rising. One thought was that, people get a lot more scans now than they ever used to, right? You walk into most emergency departments and say your tummy aches, and you say I ate something that didn't taste right, they'd still scan your abdomen even though you probably had food poisoning, right? It's a little silly, but that's what happens. So people get scanned for all sorts of things now that they probably don't need a scan, and they see a small mass or something like that. I had a patient who her husband was getting an MRI because he had chronic back issues and no one knew what it was from, and so he got an MRI, and the MRI place had a 2-for-1 special on, so she got an MRI and she found out she had a renal mass. We used to think that because people were getting imaged, that's why we were finding more and more of these. But when you account for the increased rates of imaging and you control for that, we still actually see it's still increasing. And it probably is increasing maybe a little bit more in women, or a little quicker maybe in women than men, but it's across the board, it's rising. And we don't know why that is. We all probably have our own personal theories. My thought is it's probably due to, we probably eat a lot more processed foods than we ever used to. And I don't know if that's why. When it's something that's a small, sort of very ubiquitous type of exposure, i.e. something in our, in our diet, it takes many years for that to accumulate to a point where it may cause a problem. And there's also a lot of individual variations, right? So, we see some people, for instance, with lung cancer who smoke a chimney, right? Smoking 4 packs a day and they never get lung cancer. And you're like, well, how did that happen? And you see someone who smoked for 5 years when they were 20 or something, and they end up with really bad lung cancer. And you're like, well, why this and why not that? And, that's just individual susceptibility. So we don't know really why overall it's rising the way it is, but it is, every year it's 2% or more that's going up. And it's not just here, it's, Canada, the UK, France, Germany, Australia, New Zealand, it's the same elsewhere.
So knowing that rates have been increasing, is there a symptom that you should look for or to know, to ask the doctor about if you happen to experience a symptom that's unusual?
Yeah, so for most people, with those small renal masses, a lot of them I had back pain on my right side, and then they get a scan done, they've got a mass on the left side. It's like, well, your back pain is because, back pain is musculoskeletal, but now you found the spot on your left side. So, you typically won't get those types of things. If you ever get blood in your urine, you need to have an evaluation for that, because that could be, a bladder tumor, it could be a kidney mass, or it could be, a mass in the lining of the kidney or the tube from the kidney down to the bladder. So those need, you need a scope to look inside your bladder, and you need a CAT scan. So if you see blood in your urine, that's not normal. That should be evaluated. Some patients will know, they'll be able to feel something, and they'll have blood in the urine and they'll have pain. If you've got that, you should be getting a scan and be getting seen ASAP, right? We used to call that the too late triad, because that was, a sign that you had a very advanced tumor. And I've had patients come in, you can look at them and they lift up their shirt and you can literally see the outline of the tumor. Clearly that is not the situation you want to be seeing someone about. You want to catch these things when they're small. When they're small, like I said, they're 99% curable with surgery if you even need surgery. So, if you feel like something wrong or, got blood in the urine, then, get it checked out. Okay.
You mentioned surgery. What's the recovery time for removal of a tumor from your kidney?
So excellent question. It depends. So some patients, if you're having a small tumor cut out of your kidney, what's called a partial nephrectomy, most of those are done robotically. That's the type of thing where you'd come in, have your surgery. Most patients would go home the next day. In some cases, some patients could even go home the same day. But that tends to be more of a rare case, but we're trying to move to that situation because patients like sleeping at home and eating home cooked food. In some bigger cases, even now we are doing more advanced robotic cases than we used to do. So some of these patients who have these large masses that go into that, that big blood vessel called a cava, that basically drains all the blood from your legs and your pelvis and your lower body back to your heart. That's a big case, right? It used to involve, vascular surgeon or a transplant surgeon. I generally do those myself, and some of them, in appropriate cases, will do them robotically. But that's a big case where we're actually opening up that big blood vessel. We have to clamp it off, open up the blood vessel, pull that tumor out, close the blood vessel. That's a case where the patient can really go home the next day or the day after. It's also a short hospital stay. There are some of those cases, though, where you've got a large mass where you can't do it robotically and you still have to do it open. And those, it varies. Some patients, we do a pretty good job. We kind of prepare for the worst. That way things go smoothly. Most of those patients, if they had surgery on a Friday, would probably go home on the Sunday or Monday. So even with those cases, patients are not really in the hospital for a very long period of time. After you get home, the recovery varies. Those who have robotic are going to get back to normal functions quicker. Those who have had open will need a little bit longer because you want things to heal properly. You don't want to go do something foolish and get a hernia and then need another operation. So, you do need to take it easy. I tell most men, they can't take the garbage out because they don't want to use their abdomen. But I tell most men's spouse that they can still sweep the floor because, that's not using their abdomen. So they shouldn't be laying in bed when they go home. But it does take a bit of time for those to heal.
Okay. Can you have a kidney cancer that spreads to your bladder or vice versa?
So you can have a type of tumor in your kidney, and that can spread down to your bladder. That is usually what's called urothelial cell carcinoma. And that's different than kidney cancer. Kidney cancer is really in the meat of the kidney. The urothelial is in the lining, and those are caused by smoking. In about a third of patients who have that in their kidney or in the lining of the tube from the kidney down to the bladder, if you go in and remove that kidney and you have to remove the tube as well, all the way down the bladder and a bit of bladder, a third of those patients will have that tumor come back in their bladder, right? And we don't know, is that cells that came down from the kidney, or is it the fact that, whatever caused that, usually carcinogens from smoking that was in the urine, the bladder's been exposed to as well, right? And so, it's a good chance that they can get it there anyways, even if they didn't have it up in their kidney. In patients who have it in the bladder, about 5% of them can get it in the kidney or the tube downwards, right? But it's less likely to go upwards, more likely to come downwards. There are very rare exceptions where you can have a kidney cancer, renal cell carcinoma, and have it metastasize to your bladder. But that is very rare, but it can happen, but not usual. Usually, if you've got it in your kidney, it goes to your bladder, it probably meant it was what's called urothelial cell carcinoma.
Okay. A couple more really good questions we have. Is Depo-Vara still used for advanced, they said RCC, so I'm assuming recurrent kidney cancer?
Depo-Vara or Depo-Provera.
Deprovara is what they typed.
Yeah, so Depo-Provera. So that was it's kind of like a contraceptive. It's a hormonal injection. And that is not used for kidney cancer, no.
Okay. A question, can a VA patient receive care from a UF Health specialist?
Yeah, so we have, it's a bit funny the way it's set up, but we have in our department at University of Florida, we have a number of faculty are at the VA. So they're University of Florida affiliate kind of, but they're at the VA. And in cases where they are not able to they don't have the expertise for one reason or another, they are able to be seen at UF itself. Yeah, so we have a number of patients. We have a very good work relationship with both the urologist and the medical oncologist there. Some of the medical oncologists at the VA work at UF as well. So there is certainly crossover. Dr. Murillo is one of the medical oncologists there. She also works here at UF. And so she knows some of the clinical trials and stuff that we have too. And so oftentimes if the patient is a good candidate, they may send them here. And so, yeah, I mean, if you talk to your urologist at the VA and you want to see someone over here, if they thought it made sense and there was, a trial or something like that, they'd have no issue with that. The urologists at the VA are all very good guys, very smart guys, and very collegial. So yeah, I don't think if it made sense, there shouldn't be too much roadblocks for that.
Okay. And then how does one get more information about the Rambo trial, or maybe even get signed up to get information about it once it goes live?
So once it goes live, it should be announced probably on the Cancer Center Bulletin. The other thing to do would be to, you could always talk to myself or one of my colleagues once it starts up. The best way to sort of find out about it, I would say, is to contact us probably in, I would say, mid to late September. It's just come back from the program office for review, so there's a couple of changes we have to make to it. And then we're hoping to get it up and running ASAP. It still does have to go through a couple other sort of hoops to get the approval and get everything teed up. And then we'll start recruiting. The nice thing with it is that if you've got a small renal mass now and you're just having it watched or something, or it's slow enough growing, which most of them are, then you could just wait a couple months and then go into the trial. So it's not like you have to make a decision now. If you've got a small mass, they grow 0.1 to 0.2 centimeters a year. If you got a 2 centimeter mass, you know, that could take 10, 20 years before you really have to do anything about it. So you've got time to sit out, wait till it is available if you really wanted to.
Okay. So the person that had that question can certainly send a message to me, and I have their information too, so I can try to get that connected if yeah,
we could also, if we get a list of that, we could also send out a notification too once it is open. Yeah.
Well, that is the end of our questions and the end of our time. So I want to thank everybody for attending today, taking the time out of your day. I appreciate that. And I really want to take time to thank you as well, Dr. O'Malley. You did a great presentation and we really appreciate it. Thank you.
Yeah, my pleasure anytime. I hope that was informative for people and I hope helpful as well.
All right. Thank you. Bye.
Yeah, bye.